Welcome to the basic course in dermatosurgery. With the help of our videos, we will give you a practical and sorted insight into the basics of dermatosurgery. At the end of the lecture series, you will know the basics of local anesthesia and have acquired theoretical knowledge about suturing. In addition, our video examples will provide an overview of the basic suturing methods and surgical flaps. We will also discuss the advantages and disadvantages of the individual techniques and their areas of application. Finally, we give you valuable tips on peri and postoperative management. We will explain the basic suturing techniques listed here in detail and show them to you step by step using memorable video lessons. When it comes to flaps, this basic course is dedicated to the most important techniques and shows you how to perform them correctly from start to finish in detail. Let's get started. Here is a second example, also in this case a 4-0 suture. This time we're looking at a monofilament, unstained and absorbable material, suitable for subcutaneous closure. Otherwise, the needle has the same characteristics as the previous example: 3/8 circle, cutting needle body, and a microtip. The needle here is 16 mm long. Now we'll have a look at the last example, a 3-0 suture, which means it is thicker than the previous ones. It is pseudo-monofilament, not stained and absorbable. This time we have different needle characteristics. Let's look at the table to see what HR stands for. H stands for a semicircle of the needle curvature, which you can again see here on the packaging. And R stands for a round body needle shape. The length of the needle is 17 mm. Do not cut the suture directly at the knot, but at a distance of approximately 1/2 centimeter. Use the first third of the scissor blade and turn the scissors slightly diagonally and upwards. Now the second simple interrupted suture follows. Make sure not to grasp the needle at the tip, but further back at the shaft. Advance the suture through the suture channel so far that approximately 2 centimeters remain on the beginning side. The suture is then knotted using the needle holder. Pull the suture perpendicularly to the wound and position the knot not on but next to the wound. The first puncture is made perpendicularly to the skin surface through the cutis and the upper third of the subcutis. The needle exits on the opposite side and is reinserted directly a few millimeters away from its exit point. This time the suture only passes through the dermis to the opposite side and exits symmetrically. As usual, the knot is placed next to the wound. It is particularly important to maintain symmetry to ensure that the suture will hold well and look aesthetically pleasing. Now let's take a look at the video. The half-buried vertical mattress suture is advantageous as it facilitates very good wound adaptation while reducing penetration trauma, thus causing less scarring than the vertical mattress suture after Donati and McMillen. The disadvantage is lower strength than the vertical mattress suture. Use the half-buried vertical mattress suture, for instance, for wounds at the hairline, as in these areas the needle should be passed as seldom as possible through the scalp. Wounds that must withstand high shear forces should not be treated with the half-buried vertical mattress suture after Allgöwer. The skin is penetrated perpendicularly, and the needle passes through the epidermis and dermis. Through supination of the wrist, the needle exits on the opposite side at the same distance from the wound edge and at the same height. A normal surgical knot is then tied, 2 loops to the right, 1 to the left, and finally another loop to the right. Now only the short suture end is cut. The long end remains connected to the needle. Reposition the needle in the holder and continue as before without knotting. The needle is always inserted on the same side. After you have performed the insertion and removal with a supination movement, re-grasp the needle, tighten the suture, and reinsert it again a few millimeters below the prior insertion point. Here you can see a wound defect that extends into the subcutis. The suture is performed in the subcutis with a complete 360-degree rotation of the needle. It connects the subcutis on both sides, taking the deepest point of the wound with it. The actual skin suture can now be undertaken. As the knot is also subcutaneous, it is imperative to use resorbable material. Let's have a look at the subcutaneous suture in a video. Start in the middle of the wound and set the first stitch in the depth of the subcutis. Use a 180-degree supination movement to guide the needle into the upper subcutis. Do not grasp the needle with the needle holder at the tip, but slightly higher. The needle bites into the deep subcutis and exits from the dermis on the same side. Use a 180-degree supination movement of the wrist to precisely guide the needle. Then draw the suture through and reseat the needle in the needle holder. The second stitch passes intradermally through the tip of the upper flap, again facilitated by a 180-degree movement of the wrist. Regrasp the needle and insert it intradermally into the tip of the second lower flap. Then draw the suture through the channel and reseat the needle for the final stitch. Here you can see the skin defect after an excision, a circle. Beginning at the upper aspect of the circular excision area, a triangle is drawn, similar to half of an elliptical excision. A lateral extension line is drawn tangentially to the lower aspect of the circle. A compensation triangle, called a Burov triangle, is drawn on the extension line opposite the circle. You will encounter the Burov triangle frequently when creating flaps. Removing this small skin triangle serves to equalize the length of the two long wound edges. Otherwise, a skin pocket, also called a dog ear, would form and sufficient wound adaptation would not be possible. The base of the triangle should measure approximately 1/3 of the extension line. The flap is now subcutaneously mobilized and slid linearly into the defect, which exemplifies the one-dimensional aspect of this flap technique. The excision area is extended symmetrically on the sides to form a U shape. In addition, at the end of both incisions, a compensation triangle should be drawn and removed. Now mobilize the flap, as well as the skin at the end of both incisions, and slide it linearly into the defect. Let's have a look at the video now. Here you can see the skin defect to be excised. Tauten the skin with the left hand and carefully excise the defect with the tip of the scalpel. Then use the anatomical forceps and separate the dermis from the subcutis. The tip of the scalpel is also useful. After the flap has been completed and subcutaneously sutured, the skin suture is performed. In this case, we implement a continuous suture. We use a continuous suture here because the wound is tension-free and the suturing process is much faster than, for example, using simple interrupted sutures. The skin is penetrated perpendicularly and the needle passes through the epidermis and dermis. Through supination of the wrist, the needle exits on the opposite side at the same distance from the wound edge and at the same height. Here you can see the execution of the continuous suture in a time-lapse video. The aim is to connect the two sides directly on the lip. For this reason, the first suture is made subcutaneously. Make sure that the two puncture points are exactly opposite each other. Remember that the first subcutaneous sutures should always be placed at the points exposed to the most tension. Tie the surgical knots, 2 loops in one direction, one loop in the opposite direction, and finally another loop in the initial direction. It is imperative to remember to use absorbable suture material for the subcutaneous sutures. Then pull the suture very tightly. At this point you can already see the planned Y of the flap. The ends of the subcutaneous suture should be cut off directly above the knot to avoid irritation. Test for sufficient wound closure by pulling on and pressing the suture. Let's look at an example of an A to T flap just below the clavicle. The lines for the axillary cuts have already been drawn at the round excision point. This A to T flap has an upside down A, while this postoperative T is right side up from our point of view. The A to T flap worked well here, since the horizontal scar lies along the natural skin folds and will therefore hardly be visible later on. As soon as you suture the flap, pay attention to a firm, but not too extreme, tension in the subcutaneous suture. Otherwise, the subcutis will be pressed too tightly and can no longer be properly supplied with blood, thus increasing the danger of necrosis. Also make sure that the needle bites are symmetrical and level with each other so that the wound is closed evenly. After surgery is complete, disinfect and clean the surgical area. We recommend the use of steri strips, which are, by the way, called wound suture strips in German. These are placed over the wound at an angle of 90 degrees and fixed under slight tension. This improves the adaptation of the wound edges. As a rule, they remain in place until the suture is removed. Finally, pressure dressings should be applied. This dressing depends on the location and size of the wound, as well as the severity of intraoperative bleeding.